So the challenges of VBID in general, and specifically in cancer care, is people ask me, what's the high value service and what's the low value service? And the good news, or the bad news, is no clinical service is always high value and always low value. The VBID idea is hung on the premise of what we call clinical nuance, that the clinical value of a service depends on who gets it, when in the course of the disease, by whom, and where. So there are some cancer drugs that are very appropriate in certain indications, or even within an indication in a certain sequence of use. So that's why we need the clinical expertise, and hopefully can leverage our electronic medical records to identify when services are actually high value in the context of that individual. Because that is hard to implement, I think that's the major challenge why value-based insurance design has been more easily implemented in diabetes and heart disease and emphysema, and less so in the actual treatment of cancer care, even though it's a flagship regarding cancer screening in the fact that we now have 140 million Americans have much better access for cancer screening because it's been identified that evidence-based screening is something that should be made available at little or no cost.